Good morning, everyone. This is Estella Balderas, and I'm with the Midwest AIDS Training and Education Center, and I'll be your webinar host today. Today's webinar is brought to you by the Public Health Institute of Metropolitan Chicago and the Midwest AIDS Training and Education Center. I'm asking for a huge favor. If you could please complete the 5-question survey at the end of the program. It's very fast, it's very quick, and that would really help us out a lot. So I present to you Erik Glenn. He is Executive Director of the Chicago Black Gay Men's Caucus. Erik?
Thank you, Estella. I hope that everyone is doing well this maybe sunny, maybe chilly, wintry kind of December morning. Thank you all for coming to the webinar today. I know that December has been tough for a lot of people, myself including. Closing out the fourth quarter is always a special event. So today we have a webinar presentation for you on the Getting to Zero HIV elimination effort that is happening in Illinois. I've had the pleasure of being one of a small group of individuals from around the state who have worked to put together an initial framework for helping us to move forward on an HIV elimination effort. I'll talk a little bit more about how this came to be, how I got involved, and whatnot. But let's just figure out and review what we're here to do today. So our objectives today are to examine and review the Getting to Zero framework. You'll see GTZ a lot during this presentation. Its development process and the upcoming GTZ action plan. Secondly, we'll apply your service experience in the discussion of practices necessary to achieve the Getting to Zero primary goals, which I'll describe in a second. Third, we'll assemble essential strategies necessary to achieve Getting to Zero primary goals. And four, learn about ongoing opportunities for individuals and organizations to continue participating in the Getting to Zero action plan process. Now, while we're talking, Jill, let me know if you can hear me a little bit more. Just type it in. Lovely. So to everyone else on the call, make sure that you use the chat function. We're actually going to be using it very specifically later on down. We're going to be trying to push the boundaries of the webinar format to make sure that we can get some participation. There will be some times where I'm asking you to complete a poll. There will be some times where I'll be asking you to respond to questions.
It's all the volume we have.
That volume here.
Uh-oh.
Stay down.
Estelle, is that you?
No, it is not.
Uh-oh. Okay, we have some,
And I'm going to try to remute the phone line.
Okay.
Oh, she wants it.
We're going to make it work, everybody. Okay, that sounds good. And after the chat discussion, we'll also be opening up the lines so that we're able to
All guests have been muted.
Just so you all know. So, where do we start? So, to get us all situated, let me tell you a little bit of the story about where we got, how we got to where we are now. We convened the Getting to Zero task force to figure out what actions we needed to take to get us to zero new infections in Illinois. The way I usually describe that, too, to make sure that we're not leaving out people who are living with HIV, we're talking about zero new infections, but also zero people who are not on treatment. I guess an extension of the conversation, too, is zero people who are detectable. So I'll look forward to hearing some of your responses to that a little bit later down in the presentation. So the task force that is here right now needs your ideas about how we can make this all reality. Your input is going to be important to make sure this work is successful and that it makes a difference for those living with HIV and those at risk for contracting HIV. So we're going to have this brief presentation, more background. The bulk of the time is going to be for you. Let's move on to the background that I keep talking about. So in 2016, people living with HIV, advocates, service providers, and government officials met to start this conversation. We had previous plans. If you're on Caucus, you know that there is the integrated plan that talks about where we want the city and the EMA, where we want the EMA to go. Previously, there was a statewide plan a few years ago. I forget the date, but we live in a different time. It's 2017. We have new tools available. We have an opportunity that we can take up right now to move the elimination effort forward. So we agreed that it was critical to explore a Getting to Zero plan for Illinois specifically, set up teams to gather community input, engage key stakeholders, and develop a framework for the plan. So you'll notice that right now we're doing some of the community engagement work, but that's for the action plan. This was for the framework. So giving us a skeleton of how did we want to proceed. And then we produced the Getting to Zero framework, and now we're conducting input gathering to inform the action plan itself. So again, why now? And these are stories that I don't need to harp on too much for all of you. This should be familiar. We have new HIV cases in new HIV cases in Illinois dropping by nearly 28% from 2006 to 2015. Now the caveat to that is across the board. For communities such as mine and the one that I serve, we haven't enjoyed the same kind of drop. So that's part of our conversation too. Illinois can boast that we have nearly eliminated mother-to-child HIV transmission. In Chicago, there have been fewer than 1,000 new HIV cases annually since 2013, which is great. Again, that's not consistent across all racial demographics or sexual demographics, but it is a success for us to lean into. We also have the fewest cases reported annually since 1990. The Affordable Care Act has given 12,000 people living with HIV healthcare coverage that they didn't have before. PrEP is up to 99% effective at preventing HIV infections when it's utilized consistently and correctly, and we see that rolling out. And U equals U is a campaign that you all may have heard of. It means undetectable equals untransmittable, which is now getting institutional backing, that if we are able to help people who are living with HIV get to an undetectable level, then the likelihood of them transmitting HIV to their partners is basically nothing. So let's see where else we are. Timeline. So just to give you an overall view of where we've been, where we are now, and where we're going. So we started in 2017. It was a one-year planning period that began resulting in the framework. AIDS Foundation of Chicago has been really great in offering some capacity. You could probably make some assumptions. A lot of our organizations are pretty stretched. We're pretty busy delivering the services that need to happen on the ground. So the idea of committing staff time to developing a framework like this sounds great in theory, but in practice can actually be kind of challenging, which for an organization like mine, where I'm a staff of 1, recently a staff of 2, yay, double my staff size, it can be hard to contribute those type of resources. So we're really thankful that the AIDS Foundation was able to hire a project manager to help with planning activities, coordinating partnerships, and supporting the drafting of the plan. I also put that out there because if you have specific questions, if you have feedback after this, the website that I give you will be located at the AIDS Foundation's website, and we'll have contact information to continue to give feedback. The plan isn't done. So between August 2017 and October 2017, we expanded the steering committee, I guess we called ourselves, to 30 public and private stakeholders. We continued with community engagement, and the Getting to Zero framework was released. And so that's something that we can, I'll go through the overview and high level, but that's something that we can distribute to the entire group. Beginning in November, so very recently, we began a new type of community engagement. This is an example to make sure that we're able to do an action plan. The framework really was about the what do we want to get to. The action plan is how are we going to get there. We're projecting in April of 2018, so this is pretty fast, that we'd have a first draft of our action plan. In May of 2018, would have completed the review of the action plan with concerns and challenges being addressed. I mean, regardless of expanding to a 30-person group, the idea of us being representative of the experiences, the ideas, the lived experience of people across the state is a pretty big job, and making sure that we get all of that and incorporate that is going to be difficult. And so pushback, critique, edits are all going to be essential to the process. June 2018, we are hoping to get it pushed out, the action plan, for approval and implementation. So just to let you know also, we've had a lot of people question, well, who exactly is this group that we're talking about? So it includes AIDS Foundation of Chicago, like I said, Alexian Brothers Housing and Health Alliance, Center on Halsted, Chicago Black Gay Men's Caucus through myself, Chicago Department of Public Health, Howard Brown Health, Illinois Department of Public Health, Illinois Public Health Association, Lake County Health Department, Northwestern University, Core Center, and University of Chicago. Now, you'll see in that list, it's still a little Chicago heavy, so a lot of our recent efforts have been to continually push to make sure that we're getting the full breadth of the state. So what did the framework end up giving us? 2 outcomes. And so before I say this, I'll let you know, I was not sold on these immediately. It really took some conversation to say, okay, I understand where this is coming from, I understand what the impact is, and I understand what the research tells us. So what 2 outcomes did we say were really going to move the needle when it comes to HIV in Illinois? And we came up with these 2. Suppressing viral load in the populations of persons living with HIV, leading to 0 people with HIV not receiving treatment. The benchmark is increasing the current rates of treatment by 20%. The second is increasing utilization of PrEP and other emerging biomedical technologies among populations vulnerable to HIV infection, leading to 0 new infections, increasing the current rates of PrEP use by 20%. So when we're talking about both of these are both biomedical interventions. There have been some questions of, well, why these as opposed to anything else? And what the research is really telling us is that we are able to get to something called functional 0, where the virus and its way of spreading through our communities cannot sustain itself without a critical mass of either people who are not on PrEP or people who are living with HIV who are detectable. This is kind of a duh for those of us in the industry, but specifically naming them as 2 outcomes changes some of the perspective that we have on the work. However, it doesn't remove the fact that we have a long path to get there. If we're saying, and so our suggestion here is that over 10 years, over the next 10 years, that if we are able to increase the rates of treatment by 20%, increase the current rates of PrEP by 20%, that we, from our statistical models, project seeing a functional 0 in once the 10-year mark is up. I was a little surprised by that, and I'm going to ask you all a question about your impressions in a second. I think it was important for me to step back and to say, you know, what is my own impression of what this could look like for our landscape? How achievable do I think it is? And for the men I work with and the people that I work with, my peers and my colleagues, how might this affect their perspective on the work that they've been doing for a long time? So I have some questions for you all. And Estella, if you could help me out. We have 3 questions. How valuable a tool is HIV treatment? How useful a tool is PrEP? And how many of your agency's clients know what PrEP is? Your best guess. So we're going to give you a couple of minutes. We're curious what people say. Okay, last votes in. Okay, Estella, if you could help me, let's show people what the results were. So here are our questions. How valuable tool is HIV treatment? So about 75% of you said essential. This is also a little bit of a duh, but it starts our conversation off by putting not only HIV treatment on the table, but also PrEP. 25% of you said only matters if you can get access to it. For how useful a tool PrEP is, it was about 50-50, skewing a little bit more towards essential. Again, only matters if you can get access to it. And then for how many of your agency's clients know what PrEP is, this is a really interesting breakdown where we have 10% of you saying everyone, 31% of you saying most, about 50% saying some, and 10% saying hardly anyone. Now, you can tell just by how the last question is skewing, it skews more towards a lot of our clients don't actually know. So we have some questions moving forward. If we're saying that our statewide HIV elimination plan hangs on HIV treatment, increasing that by 20%, and PrEP usage, increasing that by 20%, we have our work cut out for us. We have another set of questions, and so Estella, if you could help me again. We have, do you believe the Illinois public health community, that's us, can achieve a 20% increase in both HIV treatment and PrEP usage over the next 10 years? The next question, do you believe that we can get to functional zero by 2026? We're going to give you a couple of minutes to really think through these because these options are a little bit different. All right, let's show the results. Again, an interesting breakdown. So do you believe that an Illinois public health community can achieve a 20% increase in both HIV treatment and PrEP usage over the next 10 years? The overwhelming majority said, yes, we can get to both of those. However, do you believe we can get to functional zero by 2026? It looks like you all were split, where, yes, we can increase both of these, but will it really get us to functional zero? And so let's continue with our slides and see what some of our modeling looks like. So I'll admit, I was also a little challenged with this. I'm not a researcher. I just know what I see on the ground. And I think a lot of you are in the same boat where, you know, we're taking the experience of working with our clients as what drives us. We've been lucky enough to have some academic partners who bring their mind share also to the group, and we've done some modeling. But before we get to the image on the right, I just want to kind of look at some of the responses to the questions that you just answered that we got from the larger community. So when we did our engagement around the state, We asked people about HIV being a valuable tool. We got 95%. Now, 75% of you said essential, 25% of you said with the caveat that we really need to get to it, so it's comparable. Many community members felt that PrEP was a useful prevention device. In our group, it was about 50, so we have a little ways to go. Majority of community believe we can get to the 2020 increase. Now, amongst you all, you had a 10% increase over what we got from the community at large. So the state at large, we had about 70%. 80% of you believe that we can make that 20% increase. Now, but only slightly more than half of those that we talked to across our state outreach believed that we could get to functional zero, even though they believed that we could get to the 2020 increase. And that was the same, I think, with the group that we're talking to today. So this means we need to do a better job as a committee putting out some of the information we're getting from our modeling. So if you look on the right, just so that you know what you're interpreting, we have the years on the bottom, taking us out a decade. We have new infections on the left. And we have these dots of where we have been in terms of new infections. And this is just new infections. The top line, the black, is if we did the same thing we're doing right now. The green is if we just increased treatments by the 20%. You can see new infections goes down. If we just increased PrEP, new infections goes down even more. And if we increased ART and PrEP, it goes down even more. So I'm curious, in the chat box, can people tell me just a little bit of your response to seeing some of this modeling? Is it something that you believe? Is it something that you have more questions about? Is it something that looks interesting, but how did you come up with these numbers? Let's take a couple of seconds. I'm eager to hear people's comments in the chat box. So if you can't see it right now, or if you're on the phone, that might be a thing where you're not able to get to the chat. It's on the right side of your screen. Jill, I know that you're able to use the chat. And Estelle, I can see you typing now too. This is also more of a test too, to make sure that you all are able to use the chat function. Oh, we got multiple people typing. Okay. Feel free to put comments and questions. For the things that I can answer as a representative who's not a researcher, I'll do what I can. And for those that I can't, this is something that I'll take back to the group, and you can consider this a critique to pass along to say, hey, if you're going to put this out there, there are certain questions that we need answered more fully. So just to read some of what I'm seeing. So what assumptions go into these numbers? I think the quick answer is the current trends and extrapolating those and saying, well, hey, if we saw these more in certain directions, what kind of output will we see? That's the best I can do as someone who's not a researcher, but it's a question I can take back. It appears that PrEP has a bigger impact on these numbers than treatment. Is that true? For PrEP, it absolutely is true because that's something that immediately is an intervention that immediately hits those who are HIV negative. And underreporting, I think a lot of us are in the same boat. Definitely, there's a whole population of people that we estimate that we don't reach. So I'm very optimistic about this, but I do hope specific strategies for populations that are challenged to get engaged in treatment, for example, individuals who are homeless, particularly if they are not chronically homeless and therefore more difficult to house, that I'm assuming that strategies would take that into account. And absolutely will, and we'll be opening the lines in a second so that we can put some of that feedback out there. How do these scenarios affect disparities in HIV incidence and infection? That's a great question. Because this is for the community as a whole, as I mentioned before, for communities like mine, we haven't enjoyed the same decrease. For Black, gay, bisexual, and same-gender loving men, in 2005, we were saying 46% of us were going to be infected with HIV in our lifetime. In 2015 and 16, it was 1 in 2. So in some ways, you could say, well, wait, has this been increasing? And if we increase the treatment and PrEP usage by 20%, what will that modeling look like? Right now, we are trying to put together modeling for different demographics so that we can make sure that we would see the same level of impact, and make sure that when we're talking about functional zero, it's not just functional zero for those who are already enjoying decreases, but we're seeing functional zero for all demographics. And whether that means that it's 20 is our ballpark for the entire population, but whether or not that means we need to tweak that number where that increase is more on one side than another. So that's an important question. Accessibility by non-ID providers needs to be increased. More education needs to be given and focused on PCPs. So what's exciting, I think, about some of your responses is that as soon as we start talking about what we want to get to, we immediately want to talk about how do we get there. And that's the conversation that we need to have as we're talking about action planning. So please hold on to these ideas. So what do we all know? And so this is a review of what we were just saying. To achieve our goal of zero new infections, functional zero, we must transition our system to one that more effectively serves the entire population of people living with HIV and all who are infected, who are vulnerable to infection. We must use strategies to lead to the most effective outcomes possible, specifically HIV treatment and PrEP. We must forge new working relationships with other system leaders to maximize our resources in order to achieve a healthier Illinois. Those are the talking points. If you are in a situation like mine, we immediately start talking about capacity, though. So as we're talking about new strategies, these have to be manageable strategies. And what I would suggest for you all is to dream big. This is feedback that we're taking not only to our group, but the governmental partners that are a part of that. And especially as elections are coming forward, we can make sure that we keep certain priorities in mind for what will be necessary to do the work that we know we need to do to get to these two outcomes. So this is just a list of the things that we would obviously say. So outreach, education, and marketing is necessary. Testing and linkage to care is necessary. Retention and engagement in care. Antiretroviral prescription and use. And what we typically call support or essential services, which is a huge catch-all. What do we do now? So these are some of the questions I'm going to be asking you in a second. We need to talk about barriers and success stories around HIV, see which ones are scalable, which ones have the biggest return on investment, barriers and success stories around prevention and testing services that we all have, thoughts around what we need to do to accomplish the two aims of the Getting to Zero framework, big ideas about how we turn the tide in the HIV epidemic in Illinois, and thoughts on why we aren't at zero yet and what we can do differently to get there. So I'm going to ask you again, chat with me. Because we have such a large group, we've opted to use the chat function and unmuting function intentionally because talking over the phone can be difficult. I have two questions for you, though, that I'd love to see responded to in the chat. These are things that I can take to the larger team and say, hey, people are curious. This is something that we need to build out strongly. What do you think is the most important thing to consider to achieve the getting to zero goals, which are zero new infections and zero people living with HIV who are not receiving treatment and are detectable? What are some of the most important things that come to mind? I think Susan has mentioned some, Michelle has mentioned some. Ooh, and multiple attendees are typing. I'm going to mention some in a second. And thank you all also. I know that I'm not the fastest typer and I'm a miserable speller, so thank you all for offering your thoughts through chat. This is going to be very helpful for us. And I'll read some of these as they start coming through. Cultural competency in healthcare, delivery to reduce stigma and fear in accessing HIV care, access to healthcare and insurance, and CBO support to healthcare providers to keep people in care. Better education and outreach to the general public on PrEP. That would definitely impact some of the low numbers that we had with awareness around PrEP. Making sure strategies are targeted to populations who are marginalized and disproportionately affected by HIV. Funding going to those most impacted by HIV. I think the provision of care is still siloed in Chicago, despite really good funding from Ryan White programs, so better coordination, absolutely. Better dissemination of information and access to care for people living outside of urban areas. Access to services, exploring public-private partnerships that can help to reduce immediate access to medications and re-engagement. Let's see about a couple of more. Access to housing, mental health, basic needs, decreasing stigma. Reframing a sexual health issue that can affect all, breaking down the silos between subgroups. So as people are chatting and typing their answers, here's the second question. If you could do anything to get us closer to zero in Illinois and money and politics were not an issue, what would you do? And so this is a dream big question. Money and politics not being an issue is one way of putting it. Another might be if you had, double or triple your budget, what kind of things would you expect to see? So here are additional answers. Regarding the framework outcome, I think it might be more effective to say all people living with HIV receiving treatment instead of zero people living with HIV who are not receiving treatment. Yeah, I think this is some of the clunkiness about naming ourselves getting to zero, is making sure that, we're kind of fitting things into that framework of language. But this is something that we can put in the larger description. Free access to PrEP, absolutely. Right now we see that there are different programs for PrEP, but it can still be a labyrinth to make sure that you are, resourced with all of those. Also, money in politics is an issue, absolutely. Ryan White supported programs go through this nightmare every year when DC decides funding, absolutely. I think this is some of the excitement over the ACA and improving the ACA is that it can help alleviate some of that nightmare. Pushing U equals U, undetectable equals untransmittable to fight stigma and to give confidence and hope to those who want to get into care. Addressing racism and stigma related to PrEP usage, absolutely, Evelyn. Homophobia and transphobia. Single-payer universal health care, I'm on board with that. Increased access to care, and PrEP education in the actual communities of populations that are most at risk, absolutely. I am in one of those communities, so I understand. Housing for HIV positive and HIV negative individuals, support services for those who are housed, housing first model, absolutely. We know in Chicago that we definitely don't have enough affordable housing or housing support programs. More focus on linkage to care, not just new to care, but also individuals who have had high or unsuppressed viral load lab results. Inconsistent medication, medical appointment adherence, more focus on coaching and counseling for people living with HIV. I would also add to that point, when we're able to identify barriers, we need to be resourced to be able to help people manage those. Many times they know their obstacles, but we may not be in a position to really assist them with that. So you all probably thought we were done typing. We are not. We're adding more questions. And sorry, Mike, why to get this last thing? Support groups for individuals and couples, absolutely. So here's another chat, and then we'll pivot for a second. So give your fingers a rest. What systemic or individual barriers do you see in staying HIV negative? How do these barriers affect the health of people you serve? This is a big question, particularly when we start to pivot from individuals and thinking, you know, our individual client by client that they need help, as opposed to, I think what Evelyn was saying in some of the chat, where we address the systemic issues of racism, homophobia, and transphobia. So if you had to give us some examples of systemic or individual barriers, what do they end up being? And thank you. I can see that we're already getting some. And some of these are the usual suspects, and it's okay that they're the usual suspects. We need to put this out there. It's 2017. Every few years, we need to make sure we're doing the same kind of inventory. Primary care, HIV care providers being willing to conduct home health care visits. That'd be awesome. Barriers, lack of access to quality, affordable, convenient health care and health education, lack of access to basic needs, hard to focus on health when people need help with housing, food, etc. Absolutely. Housing, affordability, access. Politicians, stop throwing LGBTQ people under the bus all the time and vilifying them. This leads to depression and risk-taking to escape the onslaught. As a social worker myself, and Jill, you know, we know each other, I am always afraid for clients that are pushed into isolation because there's no access to services at that point. Unstable funding for prevention. Physicians not yet supportive, informed enough to recommend support decisions to start PrEP. You know, I'm just going to vamp a little bit while you all are typing. I know from a lot of the focus groups that we've done with Black, gay, bisexual, and same-gender-loving men in Chicago that a lot of them were confused that their doctors wouldn't proactively offer them PrEP, which was a little surprising to me, but a little exciting too. I think their point of view was that their doctors really were they had the knowledge. So why should they be responsible for knowing more about healthcare than their doctor does? And I understand the frustration. Let me see. Unstable funding for prevention, absolutely. Physicians not yet supportive, informed enough to recommend, I already read this, sorry. HIV misinformation endorsed in the community, absolutely. We still see there's a lot of work to do with media outlets to make sure that they represent our issues well, but also correctly characterize different health issues and take responsibility for education and avoiding miseducation or misinformation. Better access to substance treatment programs in the community. Here's a second question for you all, and it may look like the first. What systemic or individual barriers do you see in getting and staying in care for people living with HIV? How do these barriers affect the health of the people that you serve? So this does start to look very similar. Distrust in the medical system, housing and employment, affordable housing, lack of adequate, accessible mental health care. And so maybe the more provocative question for you all is, what do you think causes these barriers in the first place? If we said, well, access to housing, and I have my own opinions, obviously, about some of these things, but I want to hear your perspectives from the people that you work with. I only work with one part of the community. If we say, let's go upstream and say, well, there's a lack of affordable housing or a lack of access to affordable housing among the people that I serve, and that is because X, Y, Z. I think you all have already started to say what undergirds the stigma that a lot of our clients experience. So I guess I would challenge the group, and hey Susan, I would challenge the group, when we're talking about racism, homophobia, transphobia, what are some examples of how that plays out in our clients' lives that impact their ability to access services or impact their ability to have the resources to take up the services that we're talking about and to achieve the health that they deserve? Okay. So racism, distrust of economically disadvantaged people, homophobia, religious bias, lack of family support, lack of adequately funded culturally sensitive programs located in the communities where the populations most recently diagnosed reside. Studies show that stress related to racism shortens the lives of persons of color. There was a very informative study about this recently on NPR. Oh my God, Susan, Facebook that to me. I would love to read it. Inequalities in access to health care services and other resources by neighborhood. Entire economic and governmental system that makes it impossible for POC to live, work, educate themselves, etc. in a way that they deserve. Jill, I think you just kind of summed it up. Okay, we're done. Thanks, everybody, for coming to the webinar. I accept LOLs in the chat box. I don't know who beeped, but that was funny. Sorry. Why don't we pivot? Just want to make sure that you all are primed for this conversation. I'm sorry. Estella, if you could help me, let's open the lines and let's see what people have to say out loud.
Okay, let me open up the lines in a little bit.
Okay, so the questions that we're going to have are, what other recommendations do you have to get us to zero? So we've talked about, in the future, what our outcomes want to be. Statistical modeling is...
All guests have been unmuted.
But the road to get there has yet to be paved. So lines are open. I feel like it's a telethon a little bit, but feel free
All guests have been muted. You can unmute your line by pressing *6.
If you are in a place where you feel like you have a lot of noise or you don't want to participate, you can press *6 to mute yourself, or you can use the function on your phone. But the lines are open. What recommendations do people have to get us to zero? And I would ask that you say your name and give us your comments. Someone at least say hi so we know that the phone lines are open.
Press star 6 to unmute your line.
I did that. Am I on?
Oh, hey, Jill.
Hey, Eric, how are you?
Sorry, this is supposed to be a very serious webinar. I apologize, everybody.
It was really good. One of the things for the second question that we found, this is Jill Dispenza at Center on Halstead, was is literally the linkage to care work, and that especially for young people, it can take extremely time and touch heavy, where it can take us 30 to 80 touches for young people to get them linked, but it's part of teaching them how to get through a healthcare system that's complicated, and that really helps with that access to care. And then we also help keep them in care because they are here at the center often hanging out, and we can check on them, see if they need anything extra, so they have more of a support system around them.
Thanks, Jill. Well, and thank you also for just putting it out there. The health system that we have right now is complicated. I still don't understand my insurance completely, and I fight with them on a regular basis.
Yeah.
So let me read the second question also to see if people have responses to the first or the second. The first one again, what other recommendations do you have to get us to zero, to pave that path, that road to get us to our ultimate outcomes? And what are you doing right now, or do you see happening right now that you feel is most effective in getting us closer to zero? I'm going to give you another minute just to think about it. We have an opportunity here to hear your voice. And if you're more comfortable, you could always just chat it out. Let's add another question to the list to see if this gets you all pumped. You don't need to raise your hand. Lines are open. What are you doing right now? Well, let's skip that. What do you see happening right now that you feel is not effective in getting us to zero, getting our communities the health that they deserve and the care that they deserve? What's happening right now that you might say, well, I'm not sure that that's very effective? And if you want to include how funding is structured, we can put that out there too. We're all friends. So we have some comments in the box. Giant testing numbers and grants versus very focused testing. And I'm assuming that's in response to what is not effective right now in getting us closer to zero. Thanks, Michelle. We also have, at CDPH, they're facilitating Getting to Zero workshops, sponsoring cultural sensitive workshops related to PrEP and Black MSM, also restructuring their bureau to focus specifically on activities and funding to support viral suppression for people living with HIV and PrEP uptake for HIV negative people. Oh, sorry. Instead of Getting to Zero workshops, undoing racism workshops. This makes a lot more sense. I didn't know you all were doing Getting to Zero. It makes a lot more sense.
Am I on, Eric, still?
Yes, ma'am.
One of the things, I'm going back to the old question that I've definitely seen with our partners here, Northwestern at the center, is literally having money for incentives and staff that spends lots and lots of time on Facebook, texting, and keeping the participants of the study engaged. And so even without a study, if you had good incentive, you brought people in every 3 to 6 months, and had people who kept them engaged and educated them every day, it totally works. They're hitting population that is not being hit by other people.
Mm-hmm.
And they're finding positives, new positives. They're getting their partners in. I mean, it's literally staff and instead of money. To me, then we're done.
Thanks, Jill. Well, and I know a lot of people feel very strongly about incentives, no incentives. I'll put it out into the space. I'm a huge fan of incentives. People need money, and they're not getting it because of, all the things that have been listed in the chat box. So it's hard for me to begrudge somebody for their hustle if it helps them survive.
And good amounts of incentives, not like $100, to come in. I mean, you're giving somebody something meaningful.
Well, and for your particular project, I mean, they're coming in, they're devoting their time.
Right. Yep.
So why not compensate them for that? Let's see now. What slide are we on? You know what, Estella, why don't we close the line again? Thank you all for your contributions. I have a
Okay.
couple more questions to ask you. Here's a question. Given all we know about HIV and how to prevent transmission, why do you think it's so hard
All
to
guests
prevent
have
HIV?
been muted.
I obviously have very strong opinions about this that I have not shared yet, and I'm thinking that you all do too. And if you want to say, hey, it's all the things we just mentioned in the chat box, that's fair too. And because of time, let's just get these last few questions out on the table. We're going to limit these to the chat box just so that we have enough time. And I'll say we're going to skip these questions, just to, my facilitator privilege right here. I'm just holding this here as a placeholder, but what have we missed? Here's the question for you all. What have we not covered so far in our conversation that needs to be out on the table? Alternatively, what questions do you still think need to get answered? I'll give you some examples from my own work. There are still research questions that I would love to see answered about my community. I would also preferably like those to be conducted by people from the community themselves. We ask different questions. We get to different information. I individually, and as ED of my organization, am curious about community assets a lot, because I know that that's not usually part of the conversation. We're usually talking about the social determinants of health that beat people down, which are a strong reality, but not so often are talking about the strengths that people bring on a community level. As social workers, I'm trained as a social worker. I struggle to come from a strength-based perspective without really paying attention to my community. And research, I think, is another tool to help give us more answers to what people are doing to help them survive, particularly in really decentralized communities. So here are some more comments. Stigma, knowing your status. Some people don't care. And I think you can mesh that with the next comment of competing needs. They have other things going on. All the things mentioned, and also youth are in a developmental stage where they think they are invincible, and so HIV won't happen to them. I think that's actually a very interesting research question, I think. Is it invincibility, or is it something else like competing attention for other things? Missed opportunities patients have with their providers that bring trauma inquiry or health risk factors. Again, how can we better coordinate? Absolutely, coordination is something. I can't tell you how often there's an organization across town working for my own community, and it's a little strange to be running Chicago Black Women's Caucus and not even know. So it's my responsibility to help centralize some of that information. Where does the rest of that responsibility lay to make sure that people know what resources are out there? And we know who's working to make sure that systems are changing or being pushed to change to serve our communities better. No one wants to take the bull by the horns. Open a primary care clinic at Steamworks. That would be very interesting, in other similar places. We know where people are. That's a meet people where they are ethic. List of not quite right beliefs that people have regarding PrEP, and then give answers to these misconceptions. Absolutely. And being able to put them out there. So in our last few minutes, let's just take a couple more comments to make sure that we get what is in your mind. Okay. So thank you all. I don't know about you, but it felt like this hour went by really fast. And in some ways, we really have only started to scratch the surface. We have a lot of things that we already know as a community of providers and provider adjacent, like those of us who don't provide direct service. So we have more information coming out. So we will have summaries coming out of all of these talkbacks, feedback sessions, input sessions, bilateral communication efforts to make sure that we can continue the conversation so that the contributions that you made today don't feel like they went to a black hole or an ivory tower, but are really part of a larger conversation about how we can get this work done in 2017, leading into 2018. So in the meantime, you can feel free to raise your voices again, and those of your staff and client by taking the survey that is in English and in Spanish. It has some of the questions that we had today, and those questions, you sure can. Let me just read these last two. Need for revised public school cultural competence, sexual health education starting in younger ages, and access to resources similar to other health services embedded within services that are already provided, such as dental services, etc. And can we please get a copy of this handout for dissemination? Sure can. I also want to let you all know that there are 2 public town halls happening in the Cook County area. One is on December 13th, which is tomorrow, from 6 to 8 at Malcolm X College. That's at 1900 West Jackson Boulevard in Chicago, and the room is 1108 Hall A, and we'll see about sending that out. And the next one is at Aunt Martha's in Park Forest from 2 to 4, and that's on December 16th, this Saturday. So there are town halls that will continue to be happening so that people are able to get opportunities to get their voices out. in some ways, the conversation we had today was kind of like a warm-up. So I would imagine you all will start to think of even more and more contributions. The survey is one way to put that in there, that we'll see it, and the town halls are there. But we are already at time, so I want to respect you all's busy schedules. Thank you all so much, and make sure to remember to answer the 5-question evaluation survey so that we know how your experience was today, and that as the webinars go forward, they're increasingly more valuable experiences for you all. So thank you.
Thank you, everyone, and I will be emailing you a copy of today's presentation as PDF, and also a link to the recording. Fingers crossed, hopefully it worked. So anyhow, if you have any questions, you can give me a call at 312-996-1484. Again, this is Estella Balderas from the Midwest AIDS Training and Education Center. Thank you and good afternoon.